figure out how I would turn on, how I would turn on my video
Okay,
in
so
Zoom.
that'll be,
That's
go
not
to
here.
Zoom,
So Zoom is here.
but then,
Oh, here it is. There
There.
we go. There we go.
okay, and so that'll be.
Oh,
That's
and-
literally Zoom.
Oh, here it is. There we go.
Okay, so that'll, that's literally Zoom.
Oh, here it is. There we go.
Okay, so that'll, that's literally Zoom.
Oh, here it is. There we go.
Now I see you.
Oh, yeah.
Put your hand up.
I'm gonna turn off the Facebook here.
Do your hand right there.
I'm gonna turn off the Facebook. Should be good.
Yeah, I think it's just a little bit, it's a little laggy, it's just lagging a little bit. So you see my, yeah, I think it's good.
Okay, now I do need to share the, like, how would I?
Oh, okay,
it
so you
come
need to
there?
get it up there.
So what are you
So,
trying to do now?
what's up, Vanessa? Okay,
What are you trying to do?
just trying to get this screen up
This
there.
thing there, you just gotta slide it over.
No, I think Vanessa just did it.
Project the screen onto there. I think you can
Up.
move it.
Yeah,
Oh. Oh, what? SubhanAllah.
yeah, it's in this.
Okay, but now how will I see this? And
But
then
we can
just
still
make it full
see-
screen?
Oh, you gotta see the screen.
I can see.
Oh, I see. I see.
You can.
So then you gotta go
I-
here. You gotta go here. I know what's up.
You can fix it.
Yeah, you
later.
can fix this. Yep. Here's my thing. now.
Yeah, there's a mirroring option. I can see it on my.
Right here, right here, right here.
Do best inshallah to kind of I don't think you'll be able to cover it all, do your best to cover whatever you can.
We'll be able to. We just gotta get this going and then we'll get started.
Hey, so how did we do the, where's the PowerPoint? All right, here, okay.
Oh, there we go. There we go. We're good. So now, let's just move this in the corner. Perfect. And let's make this full screen. Let's get started. And is this what is being shared now? How does it look? I don't know. I don't know how
It's like a bit of a lag, so, yeah.
Okay. All right.
So you're on the top. There's a little bit of a lag.
Okay, perfect. All right, Bismillah. Bismillah. All right, everybody, let's
go.
we got to move, and I apologize for the technical delay. SubhanAllah. So let's get started. We do have a lot to cover. I am not sure if we'll be able to cover everything. We will, inshallah, see if there's time for Q&A. Most likely we will not. We will move the Q&A to our Telegram group or our email address on Gmail, inshallah. So today's topic is trauma and other stressor related disorders. We're going to be talking about three specific topics underneath this umbrella. We're going to talk about acute stress disorder, adjustment disorder, and post-traumatic stress disorder, or PTSD. So let's get right into it. So, what are the types of trauma? What are the types of trauma? And let's talk a little bit about different types of trauma. So we have trauma that is acute trauma, and acute trauma refers to like a one-time traumatic event. Examples include a car accident, a natural disaster, a sudden death of a loved one, physical or sexual assault by someone to someone. So these are like acute traumas that are they happen, and then, that's the incident, it's over. And then we get into and talk a little bit about chronic traumas. Chronic trauma are these types of trauma are persistent. So it's not a one and done deal. They're persistent, include bullying. It's a big one for school-age students. Bullying in school is a big one. It could be verbal bullying, physical bullying. It could be cyber bullying, emotional bullying. There are a whole host of different types of bullying. Sisters, everybody, let's pay attention, please. Bismillah. So bullying, also neglect. And what do we mean by neglect? Neglect is it's a chronic trauma, as in if a child feels neglected by their parents. And I don't just mean, there's no food to eat, there's no electricity at home, and they're just doing, they're just there. Neglect could be emotional neglect. A parent is not emotionally available for their child is a form of emotional neglect. There's physical neglect. There's financial neglect. There are all sorts of different types of neglect. And then, abuse. Abuse is another type of chronic trauma. Examples include emotional abuse, psychological abuse, which is basically mental abuse. Also physical abuse, any type of physical abuse, as well as sexual abuse. Also, type of chronic trauma is domestic violence, or is in the case of a child, if somebody witnesses domestic violence. That is also just witnessing our caregivers, parents involved in either arguing or fighting or physically abusing each other. This is also a type of chronic trauma. Now, complex trauma, similar to chronic trauma, except that these are repeated cycles of trauma. Repeated cycles of trauma that are basically the individual does not feel that there's any way out of this. There's a sense of being stuck, and there's no way of getting out of this cycle of abuse and trauma. And when this goes on chronically over a period of years and years, we call this chronic complex trauma. And so there's a sense of feeling trapped. That's an essential feature of this type of trauma. We're gonna, inshallah, this is a topic that's very close to my heart. We're gonna have another total separate workshop on this topic alone, which is adverse childhood experiences. We call them ACEs, adverse childhood experiences. And what these are essentially are a wide range of difficult situations that children either directly face or encounter, or they witness while they're growing up from a young age. And this actually starts even before birth. So, babies can hear in the stomach, right? We know babies can hear, babies can feel, babies can hear, they can get a sense of things. If a mother is very stressed in her pregnancy, stress hormones like cortisol get released into the body, affects the baby. Stress, anxiety, worries that are excessive will affect the baby. So adverse childhood experiences, children experience these adverse events before they've developed any type of meaningful, effective coping skill. And so this can disrupt their normal course of development. And, this emotional injury actually is chronic. And if it's not treated or processed, it is lifelong. Let me repeat that. If these childhood adverse experiences that a child experiences, if they're not processed, treated, or taken care of as these things are happening, then these become lifelong chronic issues with emotional regulation, issues with distress tolerance, issues with relational, intense, rocky relationships that people can't just regulate themselves. And this goes well into adulthood, and they are a precursor to developing personality traits or personality disorders that are very difficult to treat, period. So what are some examples of ACEs? Loss of a parent, somebody loses their parent at a young age. Neglect, again, we talked a little bit about neglect. Emotional, physical, or sexual abuse, we talked about that. Divorce of parents, parental divorce. No matter how kind or respectable it might be, it's a trauma for a child. They're torn, right? May Allah protect all of our children. Divorce, separation, witnessing DV. This is so DV is domestic violence. So if a child witnesses domestic violence, that's another type of ACE. Incarcerated household members. Incarcerated household members is a type of trauma for a child growing up. And also, if there's drugs being used in the house, if children see or experience drugs being used in the house by caregivers, siblings, etc. And also caregivers with untreated mental health issues and conditions and disorders in the house, So maybe our parents or someone, uncles, whoever's living in the house, siblings, even older, if they have issues with depression, anxiety, substance use, and this will be a type of trauma for a child who's in this household. So now let's get into our first one, acute stress disorder. It is basically a precursor to PTSD or post-traumatic stress. And it's exactly what it sounds like. It happens in response to experiencing or witnessing a traumatic event that induces a strong emotional response within the individual. So, what type of things can result in acute stress? Combat, wars, right? Someone's physically assaulted, rape in females, torture, natural disasters, serious accidents. So all of these things are types of traumas that can result in acute stress symptoms, and we're going to get into these symptoms. And again, it's a precursor, meaning that it's acute stress because it goes from 1 day after the incident up to a month. If the symptoms last and resolve within the month, it's termed acute stress. If the symptoms after this trauma go into the second month, third month, fourth month, after a month, the diagnosis changes from acute stress to PTSD, to post-traumatic stress disorder. So let's talk about a little bit about some information about the prevalence. How prevalent is acute stress? Individuals experiencing trauma. 7% in the US. We're talking about 330 million individuals in the US. 7% of that, I don't know the math. It's a lot of people. That's a lot of people, and that's a whole lot of people, hundreds of thousands of people. And 30% in US Vietnam War veterans. So subhanAllah, 30% in war veterans. And I work at the KCVA, work with veterans pretty consistently, and we see them come in, and a lot of them are service connected. What's termed service connection for PTSD, meaning they're unable to function physically, emotionally, hold down a job, and because they're disabled due to their PTSD, they get money from the government depending on how severe their PTSD is. So it can be very devastating, subhanAllah. So diagnostic criteria, number one, the criterion A, exposure to actual. So pay attention to these. These are the same as this diagnostic criteria, according to the DSM, is going to be the same criteria for PTSD. They're the exact same. There's not much difference. And so exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. So number one, it has to be a direct experience, like we directly experienced it ourselves, firsthand. Second would be either we experienced it, the traumatic event ourselves, or we witnessed someone going through a traumatic event, and we physically witnessed it. We were there, we were present, and we witnessed it. So that's the second way of developing this acute stress. Third is learning that the events occurred to a close family member or a close friend. Now, we didn't witness it, we didn't experience it, but we learned that something traumatic happened to a close family member or a very close friend. But there's a note, there's a caveat to this, which is if it happens to a family member or a close friend, it has to be accidental or violent in nature. It has to be accidental, or like, oh, my father, just got into a car accident. My friend just, I don't know, got hit by lightning. That's a bit extreme, but that usually doesn't happen. But you get the idea. We hear about it, and it's a close friend, or so it has to be accidental or something violent, or someone got jumped, or someone got robbed, or something happened, and they're seriously hurt, and they're in the hospital, and they're in ICU, and we learn about it. So, and the fourth is experiencing repeated or extreme exposure. So experiencing extreme exposure or repeated to like very graphic and aversive details of traumatic events. For example, paramedics, firefighters, police officers, there's a crash on the highway, they're collecting limbs, right? There's a crash on the highway. Now people are in pieces, literally, it was a bad crash. And they're collecting, and they do this day in and day out. There's a fire, they're pulling out charred bodies, from the fire, or people that are, have their skins falling off, and they see this, and they witness this. And this is also called vicarious or secondary trauma because it's not happening to them, but they see it. It's a trauma through because of their jobs. Yeah, we can skip that. So that's the first thing. Those are, if neither of those four things are present, it is not acute stress. We can't say it's acute stress. Second thing is there has to be a presence of 9 or more of the following symptoms within from 5 categories. And these categories are intrusion, negative mood, dissociation, avoidance, and arousal. And these have to begin, these symptoms have to begin either right after the traumatic event, or they have to get worse after this event has happened. And so we're going to talk about these 5 categories in detail. What is intrusion? Intrusion is basically, when someone is an intruder, when someone intrudes, there's an intruder alert or something, that means that something's unwanted. It's unwanted. We don't want it. We don't want to, we're not actively trying to think or be in that space, but it intrudes. So part of this, number one, is recurrent and involuntary memories. Like something very traumatic happened and we're there washing dishes, watching TV, scrolling on our phones, and all of a sudden our mind gets hit with that trauma, that memory just comes and intrudes in the middle of whatever we're doing. And it's like, we're not even thinking about anything like that. And it just won't leave us alone. It just keeps intruding. So that's one thing. Recurrent memories, intrusive, call them intrusive thoughts that bother. And in children, this is kind of seen as they will kind of play out the trauma. We've seen movies where children who have experienced traumatic events, they'll kind of start playing out whatever they saw or witnessed or experienced, and the mother or the father will run up like, don't do that. And it's like, that's how a child kind of expresses their trauma. Number 2 is what we call nightmares, or nightmares that are related to the traumatic event. These nightmares are associated with sleep disturbance. And so if you sleep at night, we're kind of back there again in that traumatic experience or that trauma and that nightmare. 3, dissociative reactions. So we have nightmares that happen when we sleep at night. Then there's flashbacks. Flashbacks they don't necessarily have to be at night. They can be anytime during the day. And this is actually very dangerous. I read an article that really, really, alarmed me. So flashbacks are essentially, like when people go to wars and combat, and they've seen things, and they've seen, cars being blown up and people being blown up, and their friends dying and all of these things. So flashbacks are like basically re-experiencing like you're back in that situation again. So veterans, for example, will feel like they're back in Iraq, or they're back in Afghanistan, or they're back somewhere, while they're in Kansas City, while they're in, New York. They could be wherever, but they will dissociate. They will feel like their mind will feel like they're back in the war zone. And the most extreme expression of this is a complete loss of awareness of the present surroundings. I read an article a while back. There was a veteran who slept with a gun in his nightstand drawer. He had some nightmares and he woke up and he was dissociating. He thought he was back in war. He picked up the gun. He took the gun out of his side table and he shot and killed his wife. And he thought he was back, and he was totally oblivious to the fact that he was at home safe. And so, so these things are dangerous and they're real, and they can cause a lot of issues. As a matter of fact, in the veteran population, it's very unfortunate and sad. 21 veterans in the US take their own lives every single day. 21 every single day. And so, they're suffering. A lot of them suffer from all of the traumas that they've experienced at war. 4th, intense or prolonged psychological or physiological reactions that happen because of either internal or external cues that resemble or remind a person of that trauma. For example, I smell something. Okay, the person who raped me, he had that cologne on. If I smell it, I start freaking out. My body starts acting up, and I go into a panic attack. This would be an external cue that would remind somebody of a traumatic event that they may have experienced, even though they could be in a cologne store or a perfume shop. They're in a safe place, but now some cue, or they're in a place that reminded them of a place where they were assaulted or robbed or jumped. But like, it's, you know, it just reminds them, it looks a little bit similar, and that causes a significant physiological or a psychological distress. They may start, you know, acting all, you know, like just, you know, isolating, acting all sorts of different ways. So these are the intrusion symptoms. Let's talk about negative mood. So negative mood includes when people experience acute stress. These are negative moods. The big one is inability to experience happiness. A lot of people that have experienced acute trauma, it's very difficult for them to experience any type of positive or happiness or satisfaction or loving feelings. They just feel detached. They may be present physically in the moment. They may be, you know, but they're very detached. They can't experience happiness. You can't make them happy. They're not there. They're not fully there. So again, we talked about dissociative symptoms a little bit, like flashbacks, you know, and so again, you know, people might look like they're in a daze. They feel like the time is moving in a weird way. It's like, you know, hey, are you here? You know, like, where are you? Like, we're in school. There's work going on. Like, and a person is like, you know, work? What? We're in school? Yeah. Well, like, what's going on? Like, are we real? Are we here? Everything feels like a dream. You know, nothing really feels real. We call this derealization. And then part of the dissociative symptoms are that because it was so traumatic, this trauma or incident, our brain, as a mechanism of protecting, you know, ourselves, it kind of, we forget. We have what we call dissociative amnesia. We forget that's like very important details about that trauma. Like, our mind just goes blank. We do not remember details. And these are details that are really not, that no one should really forget. They were very powerful, but our mind just does not remember these details. Okay, and avoidance symptoms. So intrusion is all of those things we talked about, the negative mood. Avoidance is we actively avoid memories of the trauma, thoughts of that trauma. We actively avoid them. We might start listening to music, right? What happens, you know, how do other people, for example, I'm at the VA, how are the veterans, you know, avoiding thinking about their trauma? Most of them are many of them, unfortunately, are using alcohol. They're using alcohol. Why? Because they cannot stand what they remember, or they cannot stand the trauma that they've experienced, the memories, the nightmares. So they use alcohol, or they use other recreational substances, drugs, just so they can escape. They tell me, you know, we self-medicate. We self-medicate because we can't deal with the reality of the trauma that we've experienced. So we rather not think about it. We avoid it. And so, you know, that's one way to avoid it. And again, there are active efforts to avoid external reminders. People will avoid, you know, people who've gone through trauma will avoid people that remind them of the trauma, places that remind them of the trauma, conversations, activities, objects, situations, anything that may, you know, give them the slightest you know, memory or resemblance, or if they feel like this is going to go wrong, or it's going to, you know, go to get into, you know, like deep waters, they will actively avoid it, to the point where I've had patients who would not go to the grocery store because they were assaulted at Walmart. And so I have patients who will say, I will not leave the house. They will not leave the house. They will not go to Walmart. Or you know, if there's a certain type of individual that fits that description, if they see anybody that looks remotely similar to that, they will not be, their heart will start pounding, they'll start sweating, shaking, trembling, feeling hot and cold, feeling ants crawling all over their bodies. And this is involuntary reaction, because now, you know, they're overwhelmed with this anxiety and this worry. And so these are some symptoms of avoidance. Arousal is another one of the 5 categories. And arousal is issues with sleep, difficulty falling asleep or staying asleep, or both, or restless sleep. So bad sleep quality. And when sleep is bad, nothing in the world is good. When people have bad sleep, they're not sleeping enough, or not sleeping soundly, not sleeping with quality sleep, nothing is good. because a lack of sleep leads to irritability, restlessness, and all sorts of other very difficult things. So sleep is, it's one of the biggest blessings that we have. And so when that's disturbed, everything else kind of, nothing else feels good. Irritable behavior and angry outbursts with little or no provocation. So people have gone through trauma. Sometimes you'll see, like, you're joking around with someone, all of a sudden they'll, like, they're still fighting you, and all of a sudden, like, it's like, whoa, what happened? We're just joking, we're having fun, we're playing games. You started like, just you went off, like, well, what happened? It's like, okay, well, what happened was that they've possibly had some trauma that, we were just joking around, but there was some sort of stress response that was activated, that was in the subconscious, where the individual felt like they were in a fight or flight mode. And it happened so quickly and unconsciously that the person just couldn't control themselves. And this is, again, irritable behavior, angry outbursts. And it's like, where did that come from? It's like, there was no need for that. Hypervigilance, I hear this a lot from patients. Hypervigilance is kind of going into the restaurant and looking around, making sure all the exits are within, a person's view, so they know exactly how to get out, or they have to sit very close to an exit, or they're always watching everyone around them at every single moment. A lot of times in veterans, they talk about this all the time. They're very hypervigilant. It's to the point where it causes, like, social problems. It's awkward. They can't relax. They're always on guard. Problems with focus and concentration, obviously, and then exaggerated. And the problems with focus and concentration ties into bad sleep. When you don't sleep well, it's hard to concentrate during the day. That kind of ties into that. Exaggerated startle response is just basically, that balloon, someone just popped a balloon. If there's a veteran in here, who's been to war and they've heard all sorts of, gunshots and bombs and all those things, a balloon goes off, they will jump and they're ready to fight. So I've had veterans tell me they hate the 4th of July with a passion. And I was like, very shocked. I'm like, 4th of July, like, we all love the 4th. Like, what are you talking about? It's like, we hate the 4th of July because when the fireworks go off, it triggers us and we dissociate. We feel like we're back in the war zone. We feel all these memories coming back. Our bodies started having panics, all of these things. So it's ironic, but, subhanAllah, or all of these other things. So that would be an exaggerated startle response. So continuing with the diagnostic criteria. So for acute stress, it has to be, the symptoms have to be 3 days up to a month. If the symptoms resolve within the month, if the symptoms of this traumatic event resolve within the month, and an individual is no longer functionally, mentally, physiologically kind of impaired, meaning they're able to function, and whatever happened, they've kind of, it was a minor car accident. I had a couple of nightmares for a few days. I'm okay. I got jumped. I got robbed. I had trouble sleeping for a week or two, but I'm good now. So this would be more acute stress. But now we're talking about, if this goes on after that, then we get into more PTSD. Very important thing. So, like all mental health issues, in psychiatry, the symptoms have to be clinically significant, or the distress or the impairment has to be so significant that it has to cause a problem in social, occupational, everyday functioning. If somebody went through a very significant trauma, but they're doing great at work, they're doing great at school, their sleep is great, their appetite's great, everything's great, but they went through pretty significant trauma, but it's not affecting their everyday life in any type of significant way, they're not meeting criteria, as in this will not count. It has to be significant enough to cause a lot of impairment. And the most important thing, it cannot be, this disturbance in mood, emotions, all of these things can't be attributed to an effect of, drugs or substances. There's the drugs out there. There's so many different types of drugs. Who will give people, people will dissociate using different types of drugs. We are all hearing about psychedelics these days. There are so many drugs that will give, mimic a lot of these symptoms of acute stress. So it can't be due to any type of recreational drug or substance. Adjustment disorder is our next one. And it looks like we got about 20 minutes. I think I think inshallah, I think we can get to it inshallah. So adjustment disorder, this is one of my, these are one of my go-to diagnoses. Essentially, what it says here is mild depression. So it's an excessive and abnormal reaction to any life stressor. So that means the response is out of proportion to the stressor or whatever the situation is. Somebody, got, I don't know, someone lost a loved one, someone, lost their job, someone lost their business, someone got divorced, someone became homeless. I don't know, these are all stressors, right? Life stressors. So the reaction is more severe than what's normally expected. And again, it has to result in social, occupational, or some type of impairment that is significant. What is the criteria? So the symptoms for mild depression have to occur they have to be within a couple of months of the stressor happening. I lost my mom, but I was fine for the first 6 months, and all of a sudden now I start feeling things. That's not an adjustment because I was fine for the first 6 months. So the symptoms have to start within the first 3 months. And so they have to be clinically significant, like we said, and they have to, it's evidenced by one or both of the following. Again, we said this: marked distress out of proportion to the severity or intensity of the stressor, while taking into account the context, cultural factors. So even certain cultures, some responses, they're like, oh, this is normal in our culture. But no, adjustment disorder would be, it's not even appropriate, even in their culture. Like, no, this is above and beyond. This reaction is above and beyond what's considered normal. And so, yeah. So again, it can't meet criteria for another mental health disorder or a worsening of a previous mental health disorder. And the symptoms are not normal bereavement. When we lose things or we lose loved ones, and there's normal bereavement, which is feeling sad, not feeling detached, not feeling happy, feeling losing interest in things. All of these things, all of these are normal part of bereavement. Even hearing voices of our loved one, almost like auditory hallucinations, even that's normal. It happens. People hear the voices of their loved one. And it does resolve over time. So the symptoms can be similar to normal bereavement. And also for adjustment disorder or mild depression, after the event, the symptoms should not continue more than 6 months. I lost my mom, yesterday, but if next year, December, I'm still feeling, very depressed, we're no longer talking about adjustment. We're talking about maybe something more like major depression or something else. And so, so what are the specifiers of, adjustment disorder? So people can have adjustment disorder with depressed mood. So low mood, cheerfulness, feeling hopeless. These are the predominant symptoms. If people have symptoms with depressed mood, with anxiety, would be a lot of nervousness, worry, jitteriness, or separation anxiety. So some people have an adjustment disorder, but instead of feeling depressed or down, they feel very anxious. They're hyper anxious all the time, worrying about everything. For example, my parent lost their job, and now me as a child, I'm worrying about the bills in the mail. Like, how are we going to pay these bills? I'm 15 years old. I'm in high school. How am I going to pay these bills? And I'm worried, and I'm anxious, and I can't focus. I can't do well in school because I can't sleep. So this would be more with anxiety. And then there's also a specifier mixed anxiety and depressed mood, which is people will have both worries and depression due to whatever that trauma or that, whatever that incident or stressor was. Some people, especially children, I'm currently working in a child adolescent psychiatry unit in Overland Park in Maryland KU campus. I'm seeing children from the ages of 6 all the way up to 17. And subhanAllah, it says here with disturbance of conduct. So disturbance of conduct is when children, especially children, when they experience some sort of stressor that they can't cope with, there's a lot of disturbance of conduct. They might stop going to school. They might run away from home. They might, start using substances. They might start destroying property, breaking things in the house, fighting with everyone, picking fights. And it's like, hey, well, what's going on? And this is what we term the disturbance of conduct. And sometimes we have a disturbance of conduct and emotions. So, some people will have a disturbance in their behavior and the way they feel. So our last topic for today is PTSD. So again, it's a mental disorder that's diagnosed after exposure to trauma, including actual or threatened death, serious injury, or sexual, should say violence, not violation. need to fix that. So we saw this before in the first slide about acute stress. So these are all the same. Let's talk a little bit about the prevalence. So PTSD, there's a lifetime prevalence of 6 to 9%, a little bit more than acute stress, and 9% of 330 million, Americans in the US. That's a whole lot of people for a lifetime of experiencing PTSD. So it's not very uncommon. So again, intuitively, it makes sense that rates are higher in emergency service personnel, firefighters, police officers, paramedics. Survivors of rape, military combat, captivity, and wars are also, at increased risk. Women, it occurs more frequently in women, 2-to-1 ratio, which is significant, with onset in the mid to late 20s. And again, if someone's been diagnosed with PTSD, they're at risk of not being able to function in their everyday lives, socially, work-wise, occupationally, etc. And they are at a greater risk for suicide. Again, we talked about veterans, 21 veterans, completing suicide on a daily basis in the US because of PTSD. What we call is they're comorbid. It goes together hand in hand. So again, PTSD prognosis. What prognosis? You might hear doctors and stuff say the word prognosis. Prognosis essentially means what is the course of this type of illness or disease, or how is it gonna, what is the outlook? What is the outcome? How is it going to be? And usually symptoms begin within the 3 months of trauma. They can last, so it can be chronic. It can last years to decades after the trauma. So PTSD symptoms can last decades and be very chronic. However, despite the fact that it's debilitating, impairing, as time goes on, there's a very significant improvement in symptoms, physical and emotional symptoms. So individuals are able to function at work, in relationships, and even in their social interactions. So although it's very traumatic, most people can get back to normal functioning. And again, individuals with PTSD are increased risk of suicidal thoughts and suicide attempts, and this risk is increased by 2 to 3-fold. What are some things that people who experience PTSD or are diagnosed with PTSD, what other types of illness and issues they can experience? So 80% of individuals diagnosed with PTSD are likely to meet criteria for another mental health disorder, including depression, anxiety, substance use, alcohol use, recreational drugs, and also personality disorders. So if somebody, imagine, look at 80% of people with PTSD probably have issues with depression, anxiety, using substances, and a lot of other things. And that's very significant and staggering. And half of the individuals that seek treatment for any type of substance use, alcohol, drugs, they also meet criteria for current PTSD. So out of 100% of people using drugs and alcohol who look for treatment, half of them have PTSD. Half of them. That's a lot. That's a lot of people. And likely they're using the substances a lot of times to self-medicate, so they can emotionally detach themselves and numb themselves, so they don't have to think about the trauma, just drink themselves to sleep. And I've had patients who don't use drugs or alcohol, but they're on such high dose. We're giving them such high doses of very strong medications, and we ask them, these medications will tranquilize you, you won't be able to feel anything. And they will tell us, we don't want to feel anything. We don't want to don't take these medications away. If you take them away, we'll start to feel the pain again. So just, this is like almost like a chemical numbness at a point. And that's scary because when we talk about the treatment of PTSD or acute stress or trauma, the treatment is the opposite of what a lot of people think. It's actually exposure. It's graded exposure in controlled environments, talking about the trauma, discussing it with professionals, processing it, reprocessing it, and kind of coming to terms with it. But if we're in a place where, you know, we're starting to, you know, like escape by using other things and substances and alcohol, then, you know, we're just basically, you know, the patient closing the eyes. And it's like, there's no cat. The cat's gone. Close the eyes. The cat's gone. And I'll just keep the eyes closed and get swallowed by the cat. Right. Maybe it's just a Pakistani proverb. Hey, inshallah. Risk factors. Risk factors, again, we talked about ACEs, right? We talked about ACEs, big one. Childhood emotional problems, likely from adverse events in childhood, prior mental health disorders, depression, OCD, panic, or a family history of mental illness, all predisposed individuals to are risk factors for developing PTSD, as opposed to other people who don't have any issues with mental health disorders in their family or themselves. They're less likely, less at risk to develop PTSD. Environmental factors. Here's a big one. And we are here in North Kansas City. There's a certain type of, we're in a certain type of socioeconomic status. We're here, middle-class individuals, for the most part. But if we look at the environmental risk factors, right, lower socioeconomic status is a risk factor, and we have no control over that. Lower education and intelligence, childhood adversity, we talked about that. We don't have any control over, children don't have any control over whatever their family circumstances are, subhanAllah. We don't have control over, how much money our parents make, or what kind of health insurance we can afford, or what kind of schools or, things we have access to. And all of these things, collectively become environmental risk factors for mental health issues, subhanAllah. And another thing is temperamental traits, such as, there's some people that are just, they don't have good coping strategies. A lot of people don't have positive coping strategies when it comes to coping with stress. So these individuals are more at risk for developing trauma-related disorders, issues, PTSD, acute stress adjustment disorders. It's because their coping strategies might be drinking, doing drugs, just kind of, reckless driving, partying. It could be, it could be just maybe getting into gangs. It could be just anything that's reckless, or, a lot stress eating. That's actually a risk. We describe stress eating or binge eating as a risky behavior associated with trauma. A lot of people that stress eat and they gain weight and become obese and morbidly obese, that's actually one of the risky self-harm behaviors that we describe. So that's something to consider as well. So peritrauma, these are risk factors at the time of the trauma, how severe the trauma is, the degree of perceived threat to life. Like if I, beat up my son, well, he's kind of young, for if I'm beating on my son, or I said my daughter, she's older, she's 6. If I'm beating her up, but like I don't think I'm doing any type of life-threatening harm, but it's it's not what I think really matters. It's my daughter's perception. If she feels like her life is in danger, that's enough. If she feels like she's in danger physically, her life is in danger, even though I know I am not gonna, kill her with a slap or a punch or a kick, but it's her perception. And so a lot of times when patients come to us and say that, we've had childhood physical, emotional abuse, and, and when I ask about that abuse, I'm like, did you feel like your life was in danger? Did you feel threatened, like you were going to get seriously hurt? Yes, I did. Maybe the caregivers didn't feel that way, but that doesn't matter. It's the person's perception. Personal injury, degree of interpersonal violence, how serious things get. And for military personnel, it makes a difference whether or not they were the perpetrator or a witness. When they killed an enemy, that makes a difference. And diagnostic criteria, we talked about all of this criteria, witnessing, either if it happened to us or we witnessed it or we learned about it. We talked about all of these criteria, intrusion symptoms, we talked about it. We talked about the dissociative symptoms of flashbacks, prolonged psychological distress, or physiological distress. We talked about all of this, avoidance, again, avoiding memories, thoughts, people, situations, places, negative cognitions and moods, again, that irritability, anger outbursts with no provocation. And then, a lot of negative self-beliefs like, I am bad, no one can be trusted, everything, is dangerous. And so these are part of negative mood and cognition. Distorted cognitions, we talked about. We talked about all of these. And arousal, we talked about, hypervigilance, reckless. So again, reckless self-destructive behavior includes binge eating, reckless driving, binge eating, substance use, spending money we don't have, all of these things. And I'm not talking about retail therapy. I'm actually talking about like spending, like thousands and thousands and thousands of dollars that we don't have and racking up credit card bills just to feel better. And again, we talked about the startle response, right? Just feeling jumpy, startled, easily startled. You hear a little, and then all of those things. We talked about that. Again, for PTSD, the criteria B, C, D, and E have to be there for a month or longer. Have to be there for a month or more. Got 5 minutes, inshallah, we will finish. G criterion is that, it has to be clinically significant. It can be due to substances. Here's a mnemonic. Yeah, here's a mnemonic. Hamza's waiting. Mnemonic for trauma is trauma. So traumatic event, again, R is for re-experiencing, A is avoidance. U is unable to function. M is month or the duration of time, and A is arousal. So we talked about all of these things. Again, everyone will get the slides that's on our email list afterwards, inshallah. So screening tools, we have something called the PCL 5, which is a screening tool for PTSD. These are 20 questions based on the diagnostic criteria that are rated from 0 to 4. And if the cumulative score adds up to about a 31 or higher, that is a positive screen for someone potentially having a provisional diagnosis of trauma or PTSD. And yeah, that's just kind of how it's scored. Lastly, for all of our nerds in the house, what's the neuroanatomy? What areas of the brain are implicated in PTSD or trauma? It's been shown that individuals that have been diagnosed with PTSD have smaller hippocampi. Hippocampus is the region of the brain that deals with memory. You can see that in the red on the right. So memory consolidation, spatial memory, learning. So individuals with PTSD have smaller hippocampi because their learning is implicated. They don't remember some things and stuff like that. Amygdala is our fear center. It's a small little gland. It's the fear center. If I had to ask you, would individuals with PTSD have a hyperactive or a hypoactive amygdala if it's the fear center? Hypo, 50% chance. If someone who's experienced a lot of trauma, would they be fearful a lot, all the time? So would it be very hyperactive or would it be less active? Yeah, okay. It would be hyperactive. So the amygdala would be hyperactive because it would be excessive fear all the time. So it would be functioning hyperactively. And the prefrontal cortex deals a lot with emotions, behavior. It's the executive part, the frontal lobe, and that has to do with just kind of executive decisioning, irrational behavior, irritability, agitation, behavioral disturbance. So these things are implicated. So we talked about the amygdala, decreased prefrontal, front part of the brain, decreased functioning there, smaller hippocampi where memories are consolidated. And here's an interesting one. Patients with PTSD have increased cortisol levels and norepinephrine. Cortisol is essentially the stress hormone, and if it is kind of released chronically in our bodies, it depresses our immune system and it makes us susceptible not just to mental health issues but also physical issues. And lastly, it's also norepinephrine again. So there's increased norepinephrine, which is another chemical, which is our fight or flight response. And people with high levels of this chemical will be very, just ready, very on edge, very anxious, worried. It's kind of associated with anxiety and fight or flight. Treatment, this will be our last slide. Alhamdulillah, we were able to finish. Treatment is, again, for medications, there's antidepressants, SSRIs, SNRIs. There's a specific medication that's FDA approved for nightmares. It's prazosin. Psychotherapy modalities. We have trauma-focused CBT, cognitive processing therapy, prolonged exposure therapy, and for children who've experienced trauma, these are especially play therapy is excellent. Play therapy, and there's certified play therapists. Play therapy, art therapy, and family therapies are effective for children. I know I kind of rushed through this last treatment slide. We are out of time. I do not have time for questions. We will defer the questions to, inshallah, we'll defer the questions to our chat and our emails, inshallah. I apologize for the technical difficulties. With that, we will not waste the Sheikh's time. He's going to talk with the sisters. Barakallahu feekum. Subhanakallah wa bihamdik wa ashhadu an la ilaha illa anta astaghfiruka wa atubu ilayk. Jazakumullahu khair. Assalamu alaikum wa rahmatullahi wa barakatuh.
Yes.
Way to turn this. How do I think someone? Last second. How do I turn this off? The live and all these things. I'm not on this. Maybe. Yeah. Oh, there we go. Is it? Oh, maybe it's up here. Oh, you know what? Yeah. Let's.
Oh wait, let's go over.
Yeah. So I think if we click on this.
How do you
Wait, hold on. I think I might just. Can I just? I'm just gonna exit Zoom.
Yeah, that's good.